Great. Well, welcome. And it really is an honor to be amongst so many leaders in the healthcare arena, in the economic forum, and I thank you very much for coming. And I also will say it's a special honor to be able to introduce Secretary Sebelius, who will talk about what the administration has been doing to try to improve women's health. But before we do that, I think this theme today of the summit has been about how women have been a critical and integral part of the economy, and vice versa, how healthcare and other different sectors affect the economy. And I think it's worth starting out by talking a little bit about why healthcare is an economic issue. You all know that healthcare comprises about 17% of the economy. The typical family premium these days is about $15,000, which especially for small businesses is a major challenge. We know that 900,000 small businesses are women-owned, so they face a particular challenge in trying to afford and provide health care for their workers. We also know that healthcare is an income security issue, that for many women, taking a new job, getting a pay increase can mean that they lose their access to Medicaid, their child could lose their access to the Children's Health Insurance Program, or switching a job can mean the loss of health insurance. In addition, we know that for seniors, and most seniors are women, it really is a major issue when premiums keep going up, when drug costs keep going up, and they really can't necessarily afford their prescription drugs or their co-pays for health care. And I think it's also important to remember that healthcare is also a jobs issue. The report that was released today, which I really recommend you all read, points out that over 75% of workers in the health and social services sector are women. So we know it's an economic issue in terms of money, it's an income security issue for women, but it's also critical in terms of jobs because women do comprise the majority of healthcare workers. Now, these are facts that we all knew when the president took office 3 years ago, and we've dedicated ourselves almost every day to be working on these issues and how we tackle them. Secretary Sebelius will talk about the Affordable Care Act and our other efforts to try to improve health, but just note that one of the reasons why we've taken all these actions is to make health care more affordable. Already, we've been driving premiums down through rate review that looks at double-digit rate increases and forces insurance companies to justify why they're so large. By trying to tackle Medicare cost growth. We've added 8 years to the life of the Medicare Trust Fund, and for the typical senior, over the next decade, they will save $4,200 as a result of the health care law. We also have been trying to tackle this issue of jobs. And since the president took office, we have tripled the National Health Service Corps. This is a service corps that provides loans and grants for people to serve in underserved communities. So we certainly are passionate about trying to improve women's health, but I think it's also equally important to recognize that our efforts to reform our healthcare system are equally important to our economic prospects. So with that, I will turn it over to Secretary Sebelius, who has not only been leading our effort to implement health reform, but taken the Department of Health and Human Services resources across the board to try to improve on a day-to-day basis the health of senior women, mothers, children, and all the people that they serve. So with that, I'll turn it over to Secretary Sebelius.
Well, thank you, Jean, and I want to join Jean and Raquel by just thanking all of you for being here today. I think this discussion is incredibly important to have, not only with those of us in this room, but it's going to be important to have over and over again with friends and neighbors and colleagues and family members as the year goes on. So today I just want to talk for just a couple of minutes about some specifics around the Affordable Care Act, but also in our department, as Jean has already suggested, with the Agency on Children and Families, we look at a lot of work-related women's issues around child care and Head Start and early Head Start. Women can't go to work unless their children are in safe and secure places. That becomes a really important focus. We look at women researchers at the NIH. We run an agency that has the workforce issues, so certainly women as healthcare providers, as service workers, as community outreach workers. But as Jean said, in the healthcare market, one of the reasons that the president was so insistent at the outset of his administration that passing comprehensive health reform was important is he recognized families really don't have security unless you have health security, that it is a very important piece of the puzzle. And for women, this bill really has an incredible impact on our lives at every step along the way. Women are the most likely to be uninsured or underinsured, just given the kind of work we do. It's more likely to be entrepreneurial or in the service industry, not have robust insurance policies. Women are the majority of beneficiaries in both Medicare and Medicaid programs. So any changes in that, any shift in beneficiary costs affect women the most, and women and their children. And in the private market, being a woman is a pre-existing condition. In the current status of the market, it is totally legal in most states in this country to charge women anywhere from 15 to 30% more for exactly the same policy that men have. And at the end of the day, those policies did not often include the benefits that women needed. So it's a lose-lose. You pay more going in and then pay a lot more out of pocket, because often whether it's contraceptive coverage or mental health services or maternity care and a number of things that are women's health issues, they were not included in the insurance policy. So women paid a lot more. The law was signed 2 years ago, and we are really already starting to see some incredibly important benefits for women. The so-called donut hole coverage, which is the seniors who take the most prescription drugs, hit a wall. There was a gap in coverage for Medicare beneficiaries, and already this year we're seeing about a $600 per person savings for those beneficiaries. And I've heard from these women all around the country, and it's a huge deal. The gap will eventually disappear over time, but it's a 50% discount this year. The access to preventive care, again, in Medicare is really important. Not only does it cover preventive services like mammograms and colon cancer screenings and cervical cancer screenings, but a wellness visit each and every year. Medicare used to cover only a welcome to Medicare visit once in your life, but to have a yearly health checkup so you don't have to wait until you're sick without co-pays or co-insurance is a huge deal for a lot of women who are involved in the Medicare program. And again, the majority beneficiaries, even at age 65, are women. As you get older, it gets to almost 2/3 of the beneficiaries are women as you go up the age category, because women live longer than men. Preventive coverage now is available through private insurance, where, again, no co-pays, no co-insurance, with women visits, with mammograms. Nearly 20 million women already have this coverage without cost sharing, and that number will continue to grow. New protections for women in the so-called Patient's Bill of Rights. So insurance companies can no longer dump people out of a policy because they have a technical problem on their health form. They have to get rid of the lifetime limits on policies. Again, that is an issue that doesn't hit a whole lot of people, but I can tell you if it hits you, and again, I've heard from a number of these folks, it is a life or death situation. You don't any longer run out of insurance coverage when you're in the middle of a cancer treatment or recovery from surgery. And what we're doing is building toward what will be a brand new market in 2014. And again, women will be huge beneficiaries from the new market, because no longer will you have to depend on where you work to be in a large insurance pool. You can be in an exchange part of a larger pool, and insurance companies will not be able to discriminate based on pre-existing condition, and they will not be able any longer to charge women more than men. I mean, it's a win-win-win situation. So women will be freer to take jobs of their own choice, to start their own businesses, to take care of their families without having to worry about health security. So I think it's safe to say that since Medicare and Medicaid were passed in the mid-60s, this is by far the most significant health law that has ever been put in place, and it will not only benefit all Americans, but as a huge benefit to women. Just giving you a tiny snapshot of the market, there are, again, major changes underway in how we deliver health services, improvements in hospital care, improvements in patient care, a lot more focus on prevention, so not waiting until people get acutely ill, but really dealing with identifying issues or problems at the front end. Again, keeping people healthier, keeping them more productive as workers has a lot to do with the economy of this country. And you know, the final thing I just mentioned, and then we really would love to have a bit of a dialogue with all of you, is another very closely related issue that I think is one that is so important to a lot of us, as particularly as mothers, but friends and relatives, is the redoubled effort to go after tobacco use in this country. It had been stalled out for years. We were at about 20% smoking rates of both adults and kids. What that means is 4,000 under 18-year-olds tries their first cigarette each and every day, and 1,000 of those kids become lifetime smokers. It's a huge health cost. It also kills 440,000 people a year. And with the new Tobacco Control Act signed by this president in one of the early days of his administration, the effort is really ramped up again, and particularly to go after tobacco companies who are off-marketing to kids, to try and prevent young Americans from ever becoming smokers in the first place, and then to help people who want to quit. A lot of people who smoke want to quit, and so giving people the resources and the help that they need to quit. But that could have not only a huge impact on our workforce, on our economy, on our healthcare costs, but certainly on the future of this country. So with that, I don't know where we want to
Yeah, if
go
we have any
first.
questions.
I have a question or a
Sure.
comment. I just want to thank you so much for making the scientific determination that contraception is a preventive healthcare service. And that is just going to result in fewer abortions and more health care for women who need contraception for reasons other than birth control. And so I just can't thank you enough, and it's just shocking to me that something like contraception is so controversial. We thought we had won that battle decades ago, but obviously we have a lot of public education to do, so.
Well, just to clarify one point, I did not make the scientific determination.
No,
But yeah, the Institute of Medicine, and the
right.
way it was really interesting, Senator Mikulski was one of the champions for this provision in the Affordable Care Act. Knowing that women's health has often been a second chapter to any health story. Just to put in perspective, the National Institutes of Health didn't even have a research protocol involving women until the mid-'80s. Insurance policies across this country did not include women's health services. I know in the mid-'90s when I was insurance commissioner, we did surveys. In Kansas, we had about 90% of the policies included Viagra, and about 20% of the policies included contraception. And that was pretty true across the country. So with this law, one of the things that we were asked to do was determine what women's health services were missing from insurance policies to make sure that they would be included in services going forward. And the Institute of Medicine did that survey and came back really with 8 different categories. One of them was contraception, domestic violence screening, mental health services, maternity coverage, help with breastfeeding and nursing moms. So it's a range of services that really add to the health of women, are pretty unique to women, but often are missing from insurance policies, and you're absolutely right. It's a huge step forward. And in August of this year, that whole package will come into play. So any new policy written on or after August 1st will have to not only include those services, but include them with no co-pays and no co-insurance, to not put up financial barriers to what are really recommended preventive services.
For people who don't have computers, for people who just can't find out, they don't go to meetings or what have you, how do they find out what takes place? I think that's probably the more difficult part of affordable health care. Is there like a chart or something?
Well, there is a website, but if you don't have a computer, I mean, hopefully that's why you're here. Because what we're going to need to do is have a lot of people, if you think about, I think, the most vulnerable communities where people maybe older speak English as a second language or are more isolated or not computer literate, this is going to have to be a kind of personal education process. We're trying to involve faith leaders and healthcare providers, and we've got some interesting partners in a lot of the big drugstores. So when somebody goes in to buy a product now at CVS and Walgreens, they're going to get a printout saying, here's what's available to you now in the Affordable Care Act, here's what's coming. So we're trying to be creative about what ways there are to give people information. Medicare, if people are over 65, they get mailings on a regular basis. They don't have to go online to find stuff, but they'll be actually given information. This is available now. Have you had your preventive checkup? Do you know that you can currently get this? But I think we'd all welcome ideas or strategies about how to do. We're trying to use social media and Twitter and all the avenues. We're printing everything in Spanish and English, but community health workers are very good advocates. But it is confusing because it phases in over time, and we want to make sure people know about the benefits.
I'm Kimberly Inez McGuire with the National Latina Institute for Reproductive Health. And as you pointed out, women are more uninsured than men, and Latinos are the most uninsured of any ethnic group. Obviously, there's so many components of the ACA that we are excited about and we're educating our communities about. But I'd love to hear from you, kind of what do you see as the biggest highlights of the ACA for Latinos?
Well, certainly closing the insurance gap is huge, because I think there's no question, and it's been documented over and over again, that having insurance doesn't just mean you've got a way to financially pay for things, but people don't access health care as frequently, don't check on things if they don't have insurance coverage. So I think that's a huge step forward. We also are really serious at HHS about looking at health disparities and trying to really drill into not only chronic disease management and issues, but what are the components? Part of it is getting more health providers in underserved areas. So as Dr. Lambrew just mentioned, tripling the number of National Health Service Corps members. That's like the Peace Corps for health workers. So the government makes a deal with nurses, nurse practitioners, docs, mental health professionals. If you serve in an underserved area, we'll help pay your student loans. I mean, it's a win-win situation. And a lot of those providers are going to be aimed at the most underserved areas. Expanding the community health networks, which is a big part of this. That is probably one of the most important backbones of preventive care, and again, targeted to underserved areas. So they were able to serve about 20 million people at the beginning of this administration. It'll move up to 40 million people with off-sites, school-based sites, nurse-run clinics, outreach areas. So, I mean, I think there are lots of strategies coming online that don't just deal with just insurance coverage, but also just an expansion of preventive care and primary care in all kinds of areas that were particularly underserved.
And I would just add one thing, which is we also, in one of the lesser known aspects of the Affordable Care Act and the President's commitment to health care, has been about children. One of the first bills that the President signed into law was the reauthorization of the Children's Health Insurance Program. We've actually covered millions more children in the last few years than there were covered when we entered the administration. And the Affordable Care Act includes special preventive services for children, continues and shores up the Children's Health Insurance Program in 2014, and really does make a commitment, because we all know children need to be well to learn. That learning then enables them to grow up and be productive and happy adults. So that's an important component we don't want to forget.
Yeah, good point.
Thank you so much for inviting us to participate in this discussion. I'm Sarah Dallo from Advocates for Youth, and I wanted to take a minute to talk about some of the benefits that students have been gaining through the changes in student health plans. We are so excited, especially me as a Georgetown University alum, about the role that contraception will need to be covered by student health plans. And as we saw Sandra Flick speak about this really important issue to students, I wanted to know if you could talk a little bit more about the other benefits that students are gaining with the changes changes to student health plans, because we're trying to rein them in a little bit and make sure students aren't taken advantage of.
Well, I think, as you know, student health plans often were pretty minimal coverage, and so there will really be a true insurance policy that will cover the health needs, preventive care, as you say, contraceptive coverage, wellness care, and it's I think a kind of plan that now parents can have some confidence that enrolling in a student health plan is actually good insurance for a college-age student. The other big initiative, and we have 2.5 million young people now taking advantage of this, that allowing young adults up to age 26 to enroll in a parent's health plan is a huge step forward. I mean, up to the passage of the Affordable Care Act, the second largest category of uninsured Americans was young Americans. And I think that often, I don't know about the rest of you, but at least my sons, when they got out of college, weren't going into work situations with insurance coverage. Our older son, who is a Georgetown grad, was going to Georgetown Law School. That didn't come with insurance coverage, and he aged out of our policy. We're still not quite sure what our younger son was doing, but it didn't come with insurance coverage. And we were pretty fortunate. You know, we could find coverage, and I knew how to do that. But I will never forget one of John's good friends had been very sick as a younger child, and he was totally healthy, 22 years old, graduates from college. His dad said to me on graduation day, "The good news is Heath has graduated. The bad news is I'm going to pay 3 times as much for his insurance as I did for his college tuition," because he had a pre-existing condition. So those days are over, and that, I think, when you think about people who, you know, may not be going to college after they're 18 or may be pursuing another activity, the freedom to choose what you want to do and be able to pursue a life dream and not have to follow insurance coverage is just huge. So.
Can I ask a question? I'm behind you, so you never see my hand. I could use your help with closing a gap in communication. The Affordable Care Act is we're starting to all understand it offers, just a vast array of resources to make an improvement. And speaking to an audience of women who are not accustomed to feeling good, feeling well. As a matter of fact, in my world, there's a concept of the strong black woman, and that is weighed by how much she can do in spite of the resistance to her spirit, her soul, her body. So I'm thinking that in addition, apparent communication to what's in the Act is a new idea who it's for. And the new idea should be a woman who is in a state of health and well-being, whose purse doesn't rattle with pills and potions, and a communication directly to the idea of the new idea of her, which in that case then would benefit. Even our amazing First Lady, who just as she stands is a sense of what health is, speaks directly mostly to the needs of children and well-being. If she could kind of add a layer of that, speaking directly to women about our entitlement to health and well-being and fitness, it might energize an idea that this is something that we need a tool for because it's our expectation for our lives.
And to connect the two questions, I mean, you asked earlier, what do we do with people who don't have access to the internet or don't know about this? One of our initiatives is try to get voices and the stories to try to illustrate both what has been accomplished thus far, but what is the potential? What does this really mean in a real person's lives? We have an initiative called MyCare. If you go to our healthcare.gov, it's called MyCare, and it is soliciting stories. Tell us what this means to you. Tell us what this is going to bring to you. How do we actually try to convey, not in the statistics, which we all can do, and in the paper and the websites, but in the real terms, what this law has meant to people, what it can mean to people, and what a healthy person could do with their lives. So thank you. It's a great
But to
summary.
your point also, I think there's a great idea that health is not the absence of sickness. It is a quality of life. It's a quality of spirit. It's a quality of mind. And there is a lot, again, tools in the Affordable Care Act. So part of it is insurance coverage for when you get sick or trying to stay healthy in the first place. But also a huge effort for the first time ever in this country around community prevention strategies, around, getting food into so-called food deserts so people can have healthier choices, looking at safer places to exercise, looking at school lunch and breakfast programs so we're not feeding our children things that are ultimately going to make them less healthy in the long run. And I think the whole universe of strategies around really looking at health as a really important component of a quality of life, not just what happens to you when you go to a doctor's office, but the whole range of issues. But that's a great idea. I love that. So, yes.
Thank you. Elizabeth, she ran that first, I think.
All right, thank you. My name is Chris Harley. I'm calling from the National Asian Pacific American Women's Forum, and one of the areas that we've been really following is both the access to healthcare for limited English proficient speakers as well as immigrants. And I'm wondering if you could talk a little bit more about the initiatives that are being implemented now to help minority and immigrant communities access the healthcare service. Because we know that, it's great to have all of these services, but when there are these barriers that prevent women from being able to access them because of language and immigration status.
Well, I would say that there are a couple of very specific initiatives contained in the new law that not only require companies for the first time to put out multilingual information, easy to read, easy to understand, but a variety of language options. There are streams of funding for the first time to make sure that culturally competent healthcare providers are in place and more training and more money available, knowing that that can be a barrier in and of itself. It's one thing to have a doctor or nurse in the neighborhood, but if they really are not sensitive to the cultural aspects, can't speak the language, don't have a way to reach out to people, they may as well be an elevator operator because people are not going to see them. So there is that stream of funding. And I think then there's a huge effort when the exchanges are up and running. There is a so-called navigator program where people will do just what you're suggesting, reach into community areas and be available kind of one at a time to help an individual navigate what is often a very complicated and complex system, make good choices. And again, those will be aimed at particular communities that have a more difficult time accessing information. So I think there are, and I'm sure there are more, but there are a number of triggers in the bill itself that kind of anticipated, getting service to the most underserved areas, and language and cultural competency is clearly there, written over and over and over again into the law. So, yes, well, I had called on this lady first. I think three times. I know.
Right.
You just the moderator.
Hi, I'm Norma Gatzik. I'm with the Feminist Majority. Thank you, as everyone has done, for many of the decisions you have made or have issued. Also, though, in talking about people knowing what this means, that is so critical, and we're finding it. And I think all of us here have a responsibility in that respect as far as getting the word out. And thank you for the information you give us. Keep the information flow. That's what I'm asking. As far as every time I come to a meeting, whether it's like this or others, I learn something new that needs to get out, or I feel we could help. And I know several groups, almost everyone in this room is involved in it, and in this process of getting information out, and it's become a focus of a group we've all formed called Her Votes, Health and Economic Rights. And but the critical piece for us is to continue to get these pieces. And I know you think, we're steeped in it, many of us, and we read so much of it, but we remember how many thousands of pages were in this bill. There can't be too much information from you as things are coming into play. As the comment you just made about, I never knew this one, the dollars for culturally competent healthcare workers was a piece I just learned, and I think that's a critical one. So,
well, let me suggest also, it's a great point, and this is a dynamic piece of legislation, so it does change, and we want to make sure that people know what's in place, what's coming, how they connect with it. We at Health and Human Services have 10 regional offices around the country, and there are wonderful experts in each of those regional offices who are eager to help do outreach, speeches, share ideas with community groups. So that's an avenue. So if you have folks in, California or Illinois or New Hampshire, we can get somebody to come to those kinds of meetings and share information. There are slide decks available that we like to get into people's hands so people can turn around and give presentations themselves. Pretty easy to use, pretty easy to understand, but kind of walk through the law so there's a common set of information. We've got handouts available. So we are eager to kind of deploy health ambassadors who are not only here in DC but around the country. And we've got some experts and eager helpers in communities across America who would be glad to join that effort. So,
Absolutely.
Lady in the brown. Hi, my name is Tiffany Turner with the National Council of Negro Women, and I wanted to say, to speak to your point, there were some additional information that I think would be great in our community. We're launching a national healthcare reform tour actually next week in 10 cities.
Oh, wow.
And your department is partnered with us. We have a speaker for every single city.
Good.
So that is, anytime he kicks us off, and we have anywhere from 300 to 800 people who are coming to each of these events. And so we're partnering with state legislators and different people to come out and talk about healthcare reform. But from the culturally competent piece, we're utilizing radio also as a mechanism because some of our, our community, they're not online.
Right.
But they're listening to the radio stations, we're getting them to come out. But I would like to, when I go online and I pull up, go to healthcare.gov and I pull up fact sheet, it would be great to get some sort of guideline that shows like when all of the different initiatives go into effect to disseminate that information to these
Right.
people. So
Sure. Okay.
that would be great, but I just wanted to say thank you so much. And if there's anybody in here that wants to partner with us, we're already paying for it, so I always so you don't have to look at, a lot of us where resources are very tight, and this is the opportunity for us to partner together so I can give you information on all the cities we're going to be in. You can invite your, members to come out. So it's not just about the National Council of Negro Women, it's about all of us as a community. So,
Did you hear about Anton's new job?
No.
Anton Gunn has been our regional director in the Atlanta office. He's coming to DC, and he's going to be the head of our outreach office here in DC. So we're thrilled.
I'll congratulate you.
Yes,
When I see you next
please.
week.
It was just announced yesterday, I think. So I just give you the news on Anton. Yeah.
I'm Lenny Preston with the Maryland Women's Coalition for
Yes.
Healthcare Reform. And
Nice to see you again.
Nice to see you. I want to thank you for coming to Baltimore. And actually, too, we just lost one of the women that shared their stories. That has been an incredible opportunity for us. And the week of the Affordable Care Act's birthday, which we celebrated, and we rolled out one of their stories each day. Usage of Facebook went up, interaction with our members. So I thank you for that. And also, one of the issues that wasn't discussed is the fact that the Department of Labor statistics show that women make 80% of the decisions, which I said that in a room full of men and they laughed. They couldn't believe it, but we, of course, know it's true. And so even when they don't know it's true, we know it's true. So, but one of the reasons our coalition was formed is that women do have such a stake in the healthcare system, not just because we're recipients of care when we can afford it, but also because we actually give the care. We provide it in hospitals and community health clinics and so forth. So perhaps you could speak to what the Affordable Care Act does in that regard for women.
Well, that's a great point. I mean, women are, as you say, not only the recipients of care, but often caregivers and often care purchasers. So, at all points along the way, getting information to women. There's a huge effort as part of the Affordable Care Act, again, to promote training more providers. A lot of people talk about the fact that, what are we going to do if all these people come into the health system and there are not enough docs? Well, frankly, we needed to pay attention to the healthcare workforce 10 years ago, but nobody was. So this president, starting with the Recovery Act, has really focused on how we get providers. And if you shift to a wellness system away from an acute care system, you need more primary care. So we're basically using all the tools in our toolbox National Health Service Corps, graduate medical education slots, payment for people who choose primary care, and treat Medicaid payments patients will be raised to Medicare rates to focus on primary care, the expansion of the National Health Service Corps. But women are kind of at the front of that line, both in hospitals, in community clinics. For the first time, the law designates nurse-run health clinics, which we are going to have now in communities across America. So there's a huge effort to recognize women as the caregivers, and also important features, in long-term care areas. Women, family members provide about 80% of long-term care. Women are often, again, at the front of that line, and there are a number of benefits that now are family care benefits to give people some respite and transportation help. I mean, what we know is that people just burn out. If you're trying to provide, raise your own family, go to work and provide care for an elderly parent, you're often in that so-called sandwich generation and get squeezed out of everything. So there are finally benefits that wrap around those families, recognizing that. So there's a lot of, I think, help and support for recognizing the roles that women play, and also, propping up those roles.
And I just might add that, in addition to, I was talking about the economic effects of healthcare, we know that breaking down the barriers between hospitals and communities and clinics and different organizations matters. Care coordination is essential, both to making healthcare more efficient, but frankly making it better, improving the quality, and improving the satisfaction of the people who work in those settings. So care coordination, medical homes, fostering accountable care organizations, really trying to think through how do we have a more sensible, seamless, coordinated system has been a top priority, supported by the Affordable Care Act, in addition to patient safety. I think we have to recognize that we have too many hospital-acquired infections, too many readmissions that are unnecessary. Through the Secretary's leadership at the Department of Health and Human Services, we have a Partnership for Patients initiative to really try to target the low-hanging fruit of unnecessary readmissions and hospital-acquired infections, which could save thousands of lives, save billions of dollars. And we have 7,000 partners who are in this initiative with us. So I don't want to leave the message without saying those points.
But can I ask one question about the so much, the one you talked about? I'm Tina Brown-Stevenson, and I'm a clinician, and I do data and analytics for Optum. And the question I had was around, so with all this new care coordination emphasis, how are we going to make all these data and all this technology interoperate, work with each other, and help a clinician to take care of people in the community as well as the hospital and all the transitions that occur between? I mean, I know there's a lot in the Act, but just like everyone else, there's so much there, I even get myself confused.
But prior to the Act, I think one of the biggest platforms for this new healthcare of the future is electronic health records. And think about this for just a minute. Think about any other major industry in this country who's still using paper files and paper records. Imagine if you had to write a check every time you paid a bill, or wait till the bank opened to get money. I mean, those days are long gone. My kids look at me like I'm talking Greek when I mean, most of the medical system still exchanges paper records and paper files. People self-report what medications they're taking. So in the Recovery Act, for the first time ever, we were directed to develop a national platform for electronic health records, which included interoperability, making sure that if systems were put in place, you could talk to one another. We're on track. We've doubled the number of doctors and hospitals using electronic health records in the last 2 years. We're on track to double it again this year, so we're up to now about 40%, which is totally unheard of. And we will, I think, be very quickly at the tipping point where once the majority of providers are using electronic health records, then the outliers become others. And I think that may be one of the most important features, not only to exchange information among healthcare providers and coordinate care, but getting patients their own information. For the first time, you will have your own health records. You will own your own health records. You will be able to help not only monitor your own care, but figure out what's going on, get information. And I think it will be one of the most important features about patient-centered care that we've ever seen. Hugely helpful to providers.
And building on that, our Innovation Center, which is now a new creation from the Affordable Care Act, will take that platform, identify what works, test it, evaluate it, and if it actually does work, Medicare policy can change. This is the first time we don't have to go back to Congress and say, here's our study, here's our evidence, change Medicare law. And Medicaid, I should say. We really have a new way of identifying what works, propagating it, and building into the system via our public programs. We know private sector often works in partnership. And in fact, almost every initiative coming out of our Innovation Center says, find a private partner. We're doing this together. So building on that platform, we have new tools that once we learn, evaluate, we can adopt.
So we have time for one more question.
Well, I just wanted to circle back to something you said in the beginning. I'm Susan Campbell with Women Heart, National Coalition for Women with Heart Disease. And women's health goes beyond reproductive care. And, heart disease is the #1 killer of women. There's a lot in the bill with preventive health services that's really going to make a difference for women, from young women moving through. And what you said about tobacco is very critical for heart disease. And tobacco is a big part of the Million Hearts campaign, which I want to give a credit to as another HHS effort to try to eliminate 1 million heart attacks over the next 5 years. Huge. And Women Heart and women in general will be taking advantage of the care that's provided through the Affordable Care Act to prevent both primary and secondary prevention of heart disease, which will improve healthcare for women overall. So thank you very much.
And as Susan knows well, the Million Hearts campaign is another targeted, focused effort to say there really are some relatively simple ways we can make people healthier. One of them is around disease management. What we know is that people with diabetes, about less than half of them really manage that diabetes. People with high cholesterol don't get the cholesterol checked and don't stay on medication. So the ABCs are basically aspirin when it's recommended for people who have had heart incidents, blood pressure control, cholesterol control, and smoking cessation. Those 4 issues, and if we really do reach out, and we're reaching out again with faith-based communities, healthcare providers, pharmacy partners, if we can address those, we can save people from 1 million heart attacks and strokes in the next 5 years. Think about that, 1 million and a number of those heart attacks and strokes are going to be women. As you say, it's the #1 killer of women right now. So there are some efforts that really shining a bright light, and in minority communities, in the Latina community and African American community, the numbers are even more stark. So these are really efforts that can also help close those disparity gaps, because if we get some focused attention on some of those issues that we can tackle. I'm really sorry. We could talk about this for a very long time. We are so grateful that all of you are here, and help us reach out, help us get the word out. Thanks for being here.
Thank you everyone for coming. If you can head back down.